So, today we are going to cover a very important topic of neuropsychiatry and also for the emergency psychiatry, that is delirium, a must know topic. You should know from very basic, from etiopathogenesis, risk factor, assessment, and then management. Okay, so let's begin. I guess it's time. So, first of all, we discuss the two case vignettes and see how we approached the cases in the emergency psychiatry. Okay, so the main crux of delirium is first we have to identify the cause, then do a complete assessment, and then decide the management. That is must thing in delirium management. Okay, identify cause, do assess every domains, and then decide the management, both pharmacological and non pharmacological. Okay, and also remember what delirium awareness day is on 12 March. Okay, this is important for the MCQ purpose. So now see, Mrityunjay, Grahita, Raj, I want all of you to participate in case vignette. Okay, do answer without any hesitation. Okay, so this 52-year-old male, he's a known case of alcohol use disorder since last 20 years and present with your emergency psychiatry unit with acute confusion, agitation. Family brought him for last 2 days. Okay, on examination you found out that the patient is bit drowsy and suddenly became very agitated, disoriented, and on examination, general physical examination, you find that there is a icterus, spider nevi, and ascites. Okay, so in neurological finding, you do neurological examination, there is hysteresis. Tremors also. Okay, so anyone, what will be your differential diagnosis and based on hepatic encephalopathy? For this, what investigation you want to go for this patient? And what other history you should take before deciding the treatment? History and investigation. Okay, very good, James. Last intake you should ask. Why? Why last intake is important? Why? You are on the right track, but last intake is important first for the diagnostic clarification. The another differential for this condition will be one is hepatic encephalopathy, another one be for which last intake is very important, benzodiazepine alcohol. Intoxication can be there. DT, very good, Sudesh, very good. So differential will be one is hepatic encephalopathy, second one is alcohol withdrawal, and third one be alcohol intoxication can also present as a delirium. Okay. For this, the investigation you want to do, one CBC you go for the LFT, KFT. This is must investigation that to be done in our emergency settings. So LFT showed 4 times raised AST and ALT, and GGT is also raised. Okay. EEG shows diffuse flowing. So the first differential will be hepatic encephalopathy. And how you manage hepatic encephalopathy, delirium due to hepatic encephalopathy? Anyone? because you get a referral for this patient also to rule out alcohol withdrawal or DT. Okay. Lorazepam, James. Okay. So that's why first we have to know how to differentiate, because the presentation is very similar in both cases. That's why you know how to differentiate hepatic encephalopathy and alcohol withdrawal delirium or DT. Okay, guys? Yes, lactulose and rifaximin. So, anyone want to tell what is the differentiating factor between hepatic encephalopathy and delirium tremors? How to differentiate these two conditions? Or two patient presenting to emergency psychiatry unit or emergency medicine department, how to differentiate these two patients, one with the hepatic encephalopathy, another with the delirium tremors? First, I guess James told the intake. Yes, flapping tremors. Okay, very good, Siddharth. Very nice. Any other thing? Just guess. Icterus. Okay. Course. Very good, Sudesh. Very good. So course will be one of the differentiating factor. Course and onset. What is the onset time for DT? Anyone? History is very important. Okay. 12 to 48 hours. 72 hours. So 3 to 4 days. सब अलग अलग भी बोलो है ना. So whatever you are telling, tell me the reference. 48 to 72 hours. That is written in where? Usually the commonly asked one, and we quote 48 to 72 hours. And in Mosley it was given up to 94 days, I guess. Mosley में थोड़ा ज़्यादा दे रखा है, but usually we quote 48 to 72 hours as per CTP. Okay, Mrityunjay, you are right. So clap for him. So now see this table. Delirium, two different patients presented with the delirium, but one is because of alcohol withdrawal, another one because of hepatic encephalopathy. Okay. With this case, Vignet, if we solve this, then we know how we should approach a case of delirium. Then we go through the text. So see, in alcohol withdrawal delirium, there is abstinence, sudden or reduction in amount. In hepatic encephalopathy, there might be infection, constipation, bleed, any other. And the underlying cause is LFT, severely deranged ammonia level raised because of deranged liver function. Okay, so patient profile in withdrawal is a chronic patient, recurrent, suddenly abstinent. In hepatic, known case of chronic alcoholism. Time onset 48 to 72 hours. Okay, but hepatic encephalopathy can happen anytime during the liver decompensation. The precipitating factor, sudden cessation, we know. Now see the level of consciousness. Usually in delirium, there the orientation is crowded. There is hyperarousability. Okay. So the chances of hyperactive delirium is more in DT as compared to hepatic encephalopathy. So in hepatic encephalopathy, usually there is a hypoactive delirium or mixed type. Psychomotor activity is usually increased in a withdrawal one and decreased or sometime increased. Tremors, like he says, flapping tremors seen in hepatic encephalopathy, and sometime fine tremors and sometime coarse tremors seen in withdrawal one. Okay, sorry, ये इधर आएगा and ये इधर आएगा. hallucination, if we see in alcohol withdrawal delirium, usually the visual hallucination and tactile are very common, but the perceptual disturbance are less common in hepatic encephalopathy. Now, the important difference is sleep wake cycle. It altered in both. Okay, so altered in both, but there is complete reversal in encephalopathy. Okay, EEG there is a fast activity, but if in hepatic encephalopathy, what we see in the EEG, there is diffuse slowing. And when you give benzodiazepine to a patient of hepatic encephalopathy, there will be worsening, because we see in delirium usually we avoid benzodiazepine anticholinergic. Okay, because it will worsen the delirium. Okay, but only delirium in which benzodiazepine is indicated alcohol withdrawal. So when you give benzodiazepine to first patient because of alcohol withdrawal, there is improvement. But if you give benzos to the hepatic encephalopathy, the condition of patient is worsened. That's why you need to know how to differentiate these two conditions. Okay, because treatment depend on that. Then the treatment for alcohol withdrawal, we know thiamine, benzodiazepine, IV fluids, and for this we know lactulose, rifaximin. Done. Is it clear, guys? Should we move forward to our next case? Okay. Second one is also interesting, and what you see in your day-to-day practice. So there is a 78-year-old male complaining of forgetfulness, impaired planning for last 4 years. But they didn't seek any medical services. But for last 24 hours, family member reported there is a worsening in sudden worsening in confusion, disorientation, patient trying to repeatedly get out the home, complaining seeing snakes, patient will not able to sleep at night and drowsy at home, drowsy at noon. On examination, patient is inattentive, not oriented, visual hallucination. Another important thing, there is a fever and suprapubic tenderness. So, the doctor advised urine analysis and issue pus and bacteria, and electrolyte is mild hyponatremia. What will be your differential diagnosis? Anyone? Mrityunjay, Hamna, Raj, Grahita. This is very simple case. Metabolic encephalopathy is okay, but see, the first one, having forgetfulness, impaired planning, age. Yes, very good, Shri. UTI, yes. So now you have to see delirium superimposed on dementia. Very good. But like Ashwin said, na, the precipitating cause is UTI. Very good, Raj Hamna. Okay. And the predisposing for delirium is dementia. And another term for this is double delirium. And in later stages of dementia, it is very difficult to differentiate the delirium and the dementia. We will go through in detail, but this is very common presentation you see. Is it clear, guys? Should we move forward? Say yes or no. Yes. Okay, Ashwin. So now we discuss the delirium. First of all, in your exam, if any question can come like assessment and management of delirium, write the predisposing factors, or any question come, first you have to write the definition from the CTP. This is must. Whether question is only about management of delirium, but first you have to write the definition. This is must thing. Then you can start with the management. Okay, so remember this definition. First, it is a complex neuropsychiatric syndrome because of structural or physiological cause which directly or indirectly affect the brain function. Okay, and cause the reversible brain dysfunction. So, complex neuropsychiatric syndrome, one or more structural or physiological abnormally affecting the brain failure function and leading to failure and causing the reversible brain dysfunction. Okay, now tell me some another name for delirium. This is very easy. So everyone tell me one name. Shri, Sid, Ashwin, Raj. Tell me another names. Organic brain syndrome. Very good. तुम लोग ही बताओगे, मैं नहीं बताऊंगी. Hmm. Okay. ICU psychosis. Very good. Acute brain psychosis. Okay. Anything? Acute brain failure. That is good. और बताओ. Acute confusion syndrome. Very good. Abhi 5 more. Sundowning is a phenomenon that seen. Okay. Acute confusional stage. सब और भी बताओ. 4 more to go. Guess. अरे टॉक्सिक मेटाबॉलिक स्टेट. अच्छा ठीक है. और बताओ. अरे गेस करो और. कोई मना नहीं कर रहा तुम्हें. कंफ्यूजनल साइकोसिस. ठीक है. CNS. Altered sensorium is a symptom, not another name. Acute brain syndrome. Okay. Or something related to encephalopathy. Toxic metabolic encephalopathy, right. Organic brain syndrome, already written. One more. Encephalitis. No, encephalitis is an inflammation. AIIMS. ना. और सोचो. Acute brain failure, already written. बताओ. Acute confusional state, acute brain psychosis, ICU psychosis, syndrome. Okay, everything is written. Very good, Shalini. Delirium. खत्म. So इनमें से कोई भी 4 नाम याद रखना और ये भी मेंशन कर देना. Cerebral insufficiency. Very good, बच्चे. And with this, we know the 10 different name for this. Okay. So remember the definition. I'm repeating it again. Any question come with the delirium, first write the definition. Now see, there are some risk factor for delirium. There are some precipitating factor, predisposing factor, and some protective factor. If we see, if a patient has age more than 65 years, having dementia, is having high myopia, known case of diabetes and hypertension, and because of arthritis is less mobile. So this patient has high chances to land up in delirium if there is a worsening, there is an infection, there is metabolic derangement or anything. So he is more predisposed to having a delirium as compared to a person who is 55-year-old, no medical comorbidity, more mobile, okay, no sensory disturbance, okay, normal sleep pattern. So as compared to this patient is more predisposed to have or land up in a delirium if any precipitating factor happen. So what are these factors? Let's see. See, there may be pre-morbid factor like age, dementia, low educational status, high comorbidity burden, visual and hearing impairment, known case of depression, use of illicit drug, and previous history of delirium. That is also important. If patient has previous history of delirium, then he has more risk to develop another episode of delirium. So there may be some precipitating factor which lend up cause this patient a delirium. If there is surgery, okay, there is acute infection, dehydration, electrolyte imbalance, LFT derangement, KFT derangement, seizure, any substance withdrawal, okay, and patient is on ventilation, patient is less mobile. So these are some precipitating factor. Then there is some post admission factor like patient is after surgery, patient is very severe pain. That is one of the important cause you see in your consultation license patient, post op patient. Invasive devices, patient is immobile after surgery. This metabolic abnormality, okay, this blood transfusion, okay, patient is on multiple drugs, patient is not able to sleep in the ICU setting, okay, lack of communication with the family, patient is lying down on the ICU bed whole day, he didn't know whether the this is the Monday, Tuesday, and the time of the day, he's unaware of the this, okay, the restraints, the psychoactive drugs, the fall risk, all longer duration of ventilation, all this worsen the condition and patient may land up in the delirium in the post-op period. Done. This is very, very important diagram from Nature Review. Okay. So in emergency department, you should know one of the most common is acute illness, dehydration, pain, sensory impairment. So if you see any patient of delirium and he used to wear a specs or hearing aid, so one of the important thing you should do in your management is provide that to the patient. Usually in ICU we remove this, and post-op period patient didn't wear the glasses and the hearing aid. This will worsen the delirium. So you should know that there is a role of sensory impairment in delirium. Patient is on multiple medication and because of surgery patient is immobile, and there is disruption of sleep wake cycle because of that monitor sound, and the hospital staff or nursing staff take blood pressure at odd timings which is required, but somehow this will disrupt the sleep wake cycle. And the malnutrition, that is one of the important thing. So now see, there is hypoxemia, metabolic derangement, which worsen lead to impairment in metabolism, will decrease the neurotransmitter, and also drugs will also keep lead to neurotransmitter imbalance. And when there is an inflammation because of infection or any other cause, there is initiation of inflammation cascade and increased cytokines, which will worsen the delirium. So, if you see what are the hypotheses for the pathogenesis of delirium, one is inflammation. Any infection which lead to initiation of inflammation cascade leads to delirium. That is our neuroinflammatory hypothesis, because it will increase the release of cytokines, the microglia get activated. Then the neurotransmitter, there is imbalance of neurotransmitters, the neuroendocrine hypothesis. Then there is oxidative, the free radical level are increased which lead to oxidative damage, the brain neuronal aging hypothesis. Then the latest one is diurnal dysregulation hypothesis. Because of this, now there are multiple trial has been going on to know the role of melatonin in delirium, emerging as one of the latest treatment. Okay, then network disconnectivity. So remember these hypotheses, at least the name, remember these two flow charts, and you are good to go while writing the etiopathogenesis. Okay. So remember, in exam you don't have enough time to write too much theory. So what you need to know, the more and core concept and 2 diagrams and one of the 2 flowchart, and you're good to go. Because in 3 hours you have to write too much. So know the core things, important diagrams. Okay. So now see, this is another very beautiful diagram. Make this beautiful diagram of brain, make some microglia, astrocyte, neurotransmitters, vascular and neuronal network. Okay, and there are some triggers. You know the trigger, whether there is a inflammation, ऑक्सीजन कम हो गया है, metabolic derangement हो गया है, microglia get activated because of cytokines, and there is neuronal dysfunction and injury. Similarly for astrocyte, drugs will lead to neurotransmitter imbalance. Endothelial or blood-brain barrier dysfunction will happen because of metabolic insufficiency, inflammation, and there is disruption of neuronal network. Okay, so remember these hypotheses. Another one, we know the neurotransmitter imbalance will happen because of various condition, because of various drug. So the most common neurotransmitter that is involved and most studied in various articles is there is increase in dopamine and decrease in acetylcholine that is seen in delirium. But it is not merely this interaction, but there is other neurotransmitter that is also involved, like glutamate, GABA, serotonin. Okay, so recently multiple trial has been going on because of role of glutamate. Okay, so that's why you avoid giving anticholinergic in delirium because it is already depleted. It will worsen the delirium. So remember this diagram also. Now see, any doubt in etiopathogenesis? Because now we go to the diagnostic part. Anyone? Raj, Shalini, James? Any doubt, bacha? Should we move forward with the assessment part, na? The most interesting one. Batao jaldi. Yeah, should I repeat any part again? The core thing that you should remember: predisposing factor, precipitating factor, protecting factor. Remember the first two. Okay. Then the hypothesis, one is inflammation, one is neurotransmitter, oxidative damage. Okay. Then aging, diurnal variation, and network disconnectivity. So target this, remember this hypothesis, make this diagram. And in neurotransmitter, remember there is a role of all neurotransmitter, but in mainly there is a role of dopamine and acetylcholine. Dopamine is increased, acetylcholine is decreased. That's why you are avoiding giving anticholinergic in patient of. Yes, beta. Constipation, like remember the first vignette we see na hepatic encephalopathy patient. Okay, so how hepatic encephalopathy developed? That patient had history of constipation, history of infection, and with because of this patient can develop hepatic encephalopathy. So it can be act as a precipitating factor. That's why you should need to evaluate this. We will see this in the examination factor. Okay, ठीक है. Hyperammonia, yes. Grahita, hyperammonemia is also can call as a precipitating factor beta when LFT is severely deranged and there is a GI bleed, and that lead to hepatic encephalopathy. Okay. Any other doubt, बच्चे? Grahita? Okay, beta. Now see how we approach a diagnosis assessment in a patient, how potassium cause it. So see, hypokalemia, hyperkalemia, hyponatremia, hypernatremia. Which is more common, hypokalemia or hyperkalemia? Anyone? Mm. Mm. Hypo is more common. Yes. Hyper is also common, but hypo is more common. So, these electrolyte imbalance, what it lead to? These metabolic impairment. We know about hypokalemia lead to cardiovascular. In CNS also. How? Conduction. Very good, bacche. Like we remember the CVS part, na? There is conduction abnormality. Similarly, there is a conduction abnormality in CNS also. Sodium potassium pump, right? देखा समझ गए. So always learn how to remember by making the connection. Neuropsychiatry is just a conceptual thing. Start making connection, start making links, see the pattern. Okay, so you don't need to mug up things. Okay, like in delirium, you don't need to mug up things except the part of the assessment tools that you need to remember. Other than that, it is common. All these four conditions can cause the delirium, even hypocalcemia, hypomagnesemia. This is also can lead to delirium. Why? Because they can alter the channels and conductions, which will impair further the neurotransmitter release. Okay, please repeat the ETO if possible. So see, ये वाला चार्ट याद रखो, बहुत अच्छा है. So factor relating to present illness. So what are precipitative? Pre-morbid से start करते हैं. What are predisposing factor? If patient is of age more than 65 or 70 years, previously having dementia, having any history of substance use, the IQ level is low, having the visual and hearing impaired, known case of depression, patient is on multiple medicines, patient is malnourished and previously having the delirium. So this patient having more incidence of having the delirium because of the damage. Which damage? Neuronal aging. Like in case of dementia, already there is a neuronal degeneration is going on in this patient, and his patient is already on drug, so neurotransmitter imbalance is already going on. Okay, so these are predisposing factor. Suddenly this patient, like consider dementia patient having any infection, like we see in the case vignette 2, patient has a UTI. It will increase the inflammation cascade, the immunity is low, this will lead to the metabolic derangement, and this will precipitate the delirium. So what are the causes? Patient go for a surgery, infection, dehydration, malnutrition, drug withdrawal, overdose. Okay. Then if patient go on the surgery, what will be the post-op causes? Patient is severe pain. Pain is not managed. Patient will have infection. The hospital stay is long. Patient is on multiple medication. Patient is not able to sleep there. The hearing aid and the visual aid is not provided. Okay. Manali, is it okay, beta? Should we move forward? Okay, beta. So, see, remember this diagram, very, very important. So, if any patient come to your clinic, emergency, how you proceed? First, you take the history, then you do the examination, and then you go for a investigation. And if required, a assessment tool. Yes, so this is very common. Okay. A patient of schizophrenia because of polypharmacy, malnutrition, might be there may be metabolic abnormality because of malnutrition that lead to that patient into delirium. So let's see. First, you take a history. In history, we have various parts which we see in detail. Then we have examination and investigation. So, medical history. What you need to ask? Substance, comorbidity, previous history of dementia, trauma. Yes, very good, James. Then review the treatment part. Then clinical examination, how you usually proceed. First you do the physical examination, you see the vital sign. Okay. Then CNS examination. In CNS you see a neurological deficit, orientation, vigilance. Okay. Then CVS, whatever system you are suspecting, do a complete examination of that system. Then do a complete MSc if it is possible. Okay. Then apply a tool. Okay. Then we proceed with some investigation. The usually we do CBC, LFT, KFT, ABG. If suspecting, do a blood culture, urine culture. ABG is must, ECG is must. If you're suspecting head injury, then you can go for a imaging also. Okay. So these are, if a substance is you are suspecting a substance induced, go for a urine tox also. Okay. Then brain imaging only if you are suspecting the structural pathology, tumor or stroke. CSF if you are suspecting the meningitis, autoimmune cause or a seizure only. Okay. So these two should be done when there is a, you have the reason for to go for this. What are the reason? Structural damage, tumor, abscess, stroke for imaging. And for CSF if you are suspecting meningitis, autoimmune cause, and EG for epileptic seizure. Okay. Now see what you, now you guys tell me what you ask in history in this patient. A patient of delirium come to your emergency department. Okay. He is 50-year-old male. Okay. Known case of diabetes, hypertension, known case of tobacco use disorder since last 35 years. And you know nothing else. How you proceed? SM Raj, बताओ कैसे प्रोसीड करेंगे बेटा. Type of symptom. Okay. Onset, duration, acute fluctuating course. Okay. Anything else? Monitor vital, sleep cycle. Okay. Now tell me any other things. Very good. Now see. In history, first you see the whatever the symptom is there, the onset, the course, the progression. Like someone tell na acute and fluctuating nature. Fluctuation, like you ask history about different caregivers, the nursing staff. Okay, the night duty on call team. Everyone give the different history about the level of consciousness. Okay, some say he is completely fine in the afternoon, but suddenly in the evening, staff tell that he is very agitated, not following any command, removing cannula. So there is a acute fluctuation, and there is a difference in the history given by different caregivers and the staff. Okay, then evaluate each symptom carefully. Present and past medical history and surgical history is must. Why? Because of role of precipitating factor, predisposing factor, even the past psychiatry history. Okay. Then current medication, very very important. Prescribed and non-prescribed. Sometime patient taking off-label some over-the-counter drugs. So you should also ask, okay, these are some prescribed and are you taking anything else? जो आप खुद से ले रहे हैं. So you should also ask this. Then substance history. Pre-morbid cognitive function. Why this is important? Can anybody tell me? बताओ. So why cognitive capacity is important? To decide treatment. Yes, Mrityunjay is right. Dementia versus delirium. So, first thing is poor cognitive reserve act as predisposing factor. Like someone told na, and another you have to differentiate whether it is delirium over dementia or patient is just having delirium. So this is important to assess delirium because the prognosis course will depend on this. Sometimes there is protected delirium. The delirium usually resolve around 48 to 92 hours worries. But in some patient having poor cognitive reserve, the course is a bit longer. Okay. Yes, to differentiate whether patient also have BPSD and we are confusing BPSD with the delirium. So that's why it is important. Very good, Carrie. Now see the symptom profile. That's why we have to evaluate the onset and course of different symptoms. The core and the non-core. The core symptom are attention, thought process abnormality, disorientation, memory. These are four important because these are very, very common. Sleep wake disturbance, motor, language. Okay. Then some are non-core like perceptual disturbance, delusion and affective changes. These are less common. Now see, what are the level of consciousness? How you can see the clinical feature will be during interview patient fall asleep. There is a fluctuating level of alertness. There is conflicting report like I said now different caregiver give the different history. Inattention, patient forget the instruction. You ask patient to draw a pentagon or hexagon for applying the MMSE, MOCAS, anything. He is not able to do and starting seeing something other thing. And easily distracted. Repeatedly asking the examiner the same question. What you ask, please repeat. And giving the different answer to the same question. Okay. So that is very, very important. In memory, patient forget meals, medicine, he don't know what day, time, place. Okay. Talking as if it has a home, talking with a disease or absent relative. Sometimes patients start naming the person who has already died. Okay. The person from his village. Okay. The childhood friend, a very distant relative. Okay. There is a construction aplegia. He is not able to draw, copy. Okay. And not able to find his way. And one of the important or key thing is disruption of sleep wake cycle. He's not able to sleep at night and become drowsy in morning. And there's a vivid dream. Okay. He's not able to distinguish whether it is a dream or reality. Then emotional. Suddenly, patient feel very anxious, fearfulness, suddenly irritable. So even in the same interview, there is a lability. He started crying and suddenly he became very agitated. So this is also common. Then there is a fluctuation, which is a characteristic feature of delirium. There is unpredictable course. If you do two MAC in two different time or even on the same day, you find a different findings. So this is unpredictable course. And there is a worsening in the symptom at evening or night. Okay. So sundowning scene is Delirium. Any other condition in where sundowning phenomenon is seen? Anyone? Dementia. Very good. So remember this question. One of important viva question. Usually we know ना delirium में होते हैं, but dementia में भी होता है and Wernicke. Okay. Wernicke is encephalopathy. Encephalopathy means delirium. So in delirium it will present as a sundowning. And apart from delirium due to any cause, dementia is another condition, especially the later stages in which you see the sundowning phenomenon. In psychomotor, you see whether it is a patient may be agitated or completely retarded. Okay, in thought there is illogical or bizarre thought, delusion, poor judgment, and speech. Sometimes it is slurred. There is a pressure. Patient find difficulty in finding the accurate word, difficulty in writing. In perceptual, visual and tactile hallucination is very common. Okay, so this is usually patient see the cannula as a snake. He try to remove the cannula. This is a common presentation you see the ICU patient. Okay, now see this is very important. The subtype of delirium, the hyperactive one in which the psychomotor activity is increased. There is a hypoactive one in psychomotor activity is decreased, and mixed form. Okay. So see in hyperactive, even in hyperactive there are three stages, so there is a fluctuation. It's not like the hyperactive patient remain in a hyperactive stage for all time. There is a fluctuation seen during the course of delirium. So these are the condition, and how you recognize in hyperactive there is agitation decreased, and in mixed there is a calm. Hallucination are common in the hyperactive one. The prognosis is more worse in a hyperactive one, and usually you get consultation or referral only for the hyperactive one. For hypoactive delirium is usually undiagnosed because no one care for them. Just patient is lying down non-interactive after a post-op period. Okay, when patient started shouting, become very aggressive, not taking medicine, then you get a referral for that patient. But the prognosis of hypoactive one is more worse than the hyperactive one, so you should know this. Okay, hyperactive is usually common in the younger population and hypoactive in the older patient. The sleep wake cycle disturbance is more common in the hyperactive one and mixed as compared to hypo. So ये टेबल भी याद रखना है. Now see, we see why medical surgery and treatment history is important, because these can act as a predisposing, precipitating factor, especially the treatment history. Like we discussed now, the polypharmacy. So there are various classes of pharmacological agent which can act as a precipitating factor as well as predisposing factor for delirium, like antihistaminic. That's why while writing a consultation, taking consultation of any patient of delirium, you first write treat the underlying patient, avoid antihistaminic, anticholinergic, benzodiazepine. Why? Because this will worsen the delirium. So this is the must note that you should write in your consultation. Okay, antihistaminic, even some antihypertensive, antiparkinson, barbiturate, benzodiazepine. Write it with your red pen. Some opioid which are given for the post-op period for the management of pain. Some tricyclic antidepressant, metoclopramide. Okay, and some over-the-counter drug. Now see, anticholinergic. These are important. Some even antibiotic, anticonvulsant, corticosteroid. That is also important. Then predisposing, some comorbidities, demographic, geriatric syndromes, premorbid conditions. And in acute, again revise infection, dehydration, surgery, medication, metabolic, nutrition, shock, surgery, pain, sleep deprivation. Okay, so we revise predisposing, precipitating multiple times. So remember this, guys. Now see, the important, you should know the correlation of what is the relationship between the dementia and delirium. You know how to differentiate. Okay, you should know how to differentiate and how these are related and how sometimes they present together. Okay, so if patient has baseline dementia, we know patient has predisposing and he has more chances to develop the delirium, because there is a neuronal aging going on, patient has more oxidative damage and there is a neuroinflammation. So this patient has more chances to land with delirium. And even after delirium, sometime even patient don't have dementia, after delirium patient can develop changes in their cognitive level because of neuronal damage, neuronal injury, and oxidative damage. So there are cases patient has previously dementia, having delirium, and there is worsening or same status of dementia after delirium. One patient with no dementia having delirium, and after delirium there is a decline in the cognitive level. This we are discussing in elderly patient. Okay, now see. There is metabolic abnormality, hypoxia, patient had delirium, which lead to neurotransmitter challenge, neuronal dysfunction, and because of this, patient land up into a dementia over course of time. Okay, is it clear, guys? Now see how you differentiate delirium versus dementia. The onset is abrupt. Dementia is insidious. This we read even before our MD for NEET, PG or INI. The duration is hours to day, but in dementia it's months to year. The attention is usually normal in dementia except in the later stages. Consciousness is generally intact in dementia while it is a characteristic feature for delirium. Okay, the cause we know for this, and the presentation. Usually delirium is hyperactive, can be hypo, mixed form depending on the level, and sleep wake cycle. Okay, and in dementia also it depend on the cause, if it is because of Alzheimer, Parkinson, Lewy body. Okay, so first you know onset, duration, level of consciousness, speech, cause, type. Done. So now you should go for an examination like we do in our MBBS time. Now start with the GPA. First you see the level of alertness because it is altered and fluctuating. Then vitals. In fever there is in infection and sepsis there is a fever. Pulse, see whether it is tachy or brady. Blood pressure, that is there is increase or decrease. If patient is shocked, there is a hypotension. Respiratory rate, tachypnea, usually during metabolic acidosis. Metabolic acidosis can be happen because of ketoacidosis, because of electrolyte abnormality, or because of any toxin, or respiratory failure. Respiratory acidosis can also happen, so tachypnea can also happen. Then oxygen saturation. So these are must thing that you should practice in your clinics or emergency, and also while writing the exam in your exam. Then hydration. Dehydration is one of the precipitating cause. Nutrition status, pallor. Okay, then icterus. Why? We see in our case vignette 1 na, cyanosis, then clubbing, okay, and pedal edema, because delirium is usually caused by the secondary. So you should first read the secondary cause leading to the delirium. Okay, this is role of antipsychotic or any other medication is just to decrease the level of aggression. It will not treat the delirium. The only treatment of delirium is treat the underlying cause. That's why we have to do complete examination. Okay, now see. Skin, see any rash for infection, any bruises, the smell, whether it is an ammonical and alcohol, see the tremors. If patient having catheter, if it is required, continue that, see if it is a source of infection, change that. Or if patient don't require it, the one of the management protocol is just remove the catheter. It will cause the discomfort and further worsen the delirium. If patient required, then continue that. For that, also see the if it is a source of infection. This is important. Bladder and bowel. The constipation and urinary retention. This will can precipitate the delirium, as one of you asked, na? That's why you should also ask the history also and see the in examination whether there is a regular bowel movement or not. Usually it is decreased in post-op period because of gastric paresis. Now in CNS, what you see, you do a higher mental function or MSC. In speech, if it's slurred, cranial nerve, whether is it normal or not. Motor function, tone, power, reflexes, okay. Aestheresis, like we see in first cases. The gait, if patient is ambulatory. Now CVS, heart rate, pulse, whether patient having rhythm is regular or not, murmurs. This will further worsen the delirium and you should treat this first. Okay. Then respiratory system, same thing. GIT, this is important. Hepatomegaly, ascites, aestheresis, jaundice. So you should do a complete system evaluation if you are suspecting these symptoms. Then genitourinary, also especially in the elderly patient, because this is very common in this patient, or patient is non-ambulatory, then there is more risk that patient has UTI. And one of the important thing is the metabolic cues. This is the examination finding. What you should do to rule out this? You should proceed with the investigation. What you do? CBC, LFT, KFT. This is must thing. ABG, ECG. If you're suspecting injury, go for a imaging. Any other investigation that you guys suggest for any patient of delirium? बताओ. Serum ammonia. If patient has hepatic encephalopathy or you are suspecting severe LFT derangement. Okay, Hamna. Good. Anything else? Serum electrolyte. Very good, Ashwin. This is must to do. Anything else? Sodium potassium serum electrolyte ऐसे. Okay. Anything else? फटाफट फटाफट जैसे तुमने नेम्स बताए थे ना, ऐसे ही सब एक 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 बताओ. Don't hesitate, just write. Only then it is LFT, RFT, okay. Urine, good. Calcium, good. Culture sensitivity, if you're suspecting UTI, you should go, especially in elderly. Magnesium, okay. If you're suspecting hypomagnesemia, you should go. ABG, that is must to do in, especially in the emergency setting, or this patient has comorbid respiratory symptom or any electrolyte abnormality. Because the report of RFT came little bit later, ABG तभी पता चल जाएगा तुम्हें sodium potassium level and you start correcting that. The more early you start management, the more better is the prognosis. CSF analysis, but as iPhone, please tell me when you are doing CSF analysis. That is important investigation, but when? Because not in every patient you do CSF analysis, na? But in which condition it is indicated? CRP and ESR, good, when you are suspecting the inflammation. But CSF, in case of raised ICT, अरे एनुरिज्म रप्चर, उसमें CSF करेंगे. Meningitis, very good. Any autoimmune condition, you're suspecting autoimmune encephalitis, you're suspecting meningitis, then you're doing a CSF analysis. Yes, Prashant. For imaging, when you do for a imaging, anyone? Neuroimaging कब करेंगे? CV, structural, very good. Like stroke, like bleed, trauma. EG कब करेंगे? बताओ. सीजर, राइट. सो व्हेन यू राइट दिस इन्वेस्टिगेशन, इनके फ्रंट में लिखना है जो तुम बोल रहे हो, ठीक है. सो मगअप करने की जरूरत नहीं है, तुम्हें खुद पता है. तो जिस चीज पे मैंने रेड मार्क करा है, दीज आर मस्ट थिंग टू डू. वन थिंग यू फॉरगॉट इज द ब्लड ग्लूकोज लेवल. इन every patient come to your emergency, you should do. Sometime hypoglycemia is one of the leading cause of delirium and we forget that. Okay. LFT, RFT, CRP, ASE, ABC, urine analysis. These only if indicated. One of things you forget, drug level, patient on lithium. Why you forget that? Toxin, urine toxic, patient is a known case of drug abuse. Okay. So these are the role. And now see, chest x-ray if you're suspecting pneumonia or any respiratory thing. ECG, if patient is a known cause of cardiovascular disorder, you're suspecting that. But in our previous hospital, when we do junior residency, ECG is done in every patient in emergency. And this is the good practice. Thyroid function test. In protected delirium, we go for a vitamin B12 or folate and toxicology. Now see the interesting thing of EEG. कब करेंगे हम सीजर में? So there is a study which I found very fascinating. So there is a scale name CAM. Okay, CAM ICU. So what is CAM? Can anyone tell me? Common है. Confusion assessment. Very good. So this is a lecture first of delirium in which we discuss the basic. The second lecture will be taken by Dr. Manish in which he discuss the tools, management and updates. Okay, so tools will be discussed by Dr. Manish in the second lecture in this. So see, so usually the CAM S, emergency CAM S is for severity also, not just for diagnosis, it's for the severity. So in this we correlate the EEG with the CAM score, CAM S score. So A is a mild delirium, moderate and severe. So now see, as patient progress into this, the waves of EEG are different. The more slowing of EEG are seen. The characteristic feature of EEG in delirium is the slowing of waves. And you see, if you see this and this, you see there is a, the rhythm is much organized in the mild one. As patient progress, the rhythm is more disorganized and there is a slowing as patient progress. Okay, so EEG slowing with increased severity. As the CAM score increase, the EEG slowing is start. And these are more theta and delta waves. And in mild, there is a more organized. You see, this is a more clearer now. As we go towards the more severe one, it become more haphazard. Okay. So mild delirium, organized rhythm, moderate to severe disorganized, high amplitude, irregular slow waves. Okay, so nowadays multiple studies has been going on as EG as a prognostic factor as well as the predicting one. We do a EG in a pre-op time and also a post-op time to predict whether this patient land up in the delirium or not. If this patient has a chances, so we initiate and do a regular investigation and preventive measures so this patient might not land up in a delirium. So let's see कैसा result रहता है. Now, these are some psychiatric differential diagnosis and that you should write in your exam in assessment part. This we discussed. First is the onset, course, the cognition, psychotic level, speech and EG. Now, DT we know the onset time, reduce attention, may have hallucination, comorbidity and in history you know the history of alcohol intake. Another thing that you should know if patient has schizophrenia. Like someone told na, a patient of schizophrenia presented with the delirium, having the malnutrition and she died. So you should know whether it is a delirium, patient has delirium and she is the known case of schizophrenia or patient has acute episode of psychosis. So you should know how to differentiate this. So the onset will be variable. Okay. And the attention is retained if it is a acute psychosis. Memory will be intact, the cognition will be intact and more psychotic symptoms. The speech is normal as compared to delirium and EEG will be normal. So that's why you should know how to differentiate acute psychosis with the delirium. This is another good differential of delirium. And also depression. How you can confuse this? You can confuse with the hyperactive delirium and this you can confuse with the hypoactive delirium. Okay, so depression onset, the course is different. The attention, the memory, cognition, in later stage it can be impaired. The psychotic symptom is usually rare and the theme is usually the mood related. The speech is normal, comorbidity can be present, and EEG is normal. Okay, so this table you should know. No need to mug up, just see. With this, the assessment is clear. Apart from the tools like screening tools, diagnostic tools, severity tools, and other, this discuss will be discussed by Dr. Manish. And the management part is also. Just see, first we screen the patient with this, then you evaluate the precipitating cause or underlying cause, then you proceed how to do the management. In management, first thing is a non-pharmacological one and a pharmacological one. What we should do? Treat the underlying cause, that is the first step. Not pharmacological, frequent reorientation that we write in every consultation. We psychoeducate patient caregiver that you should reorient patient about a time, place, situation, promote the sleep hygiene. As patient become well, encourage the physical activity and mobility. Okay, and involvement of family member. If patient has visual on hearing aid and visual glasses, just provide them. If patient is severely agitated, only then you can give a antipsychotic or any other agent. And frequent reassessment is very important. Okay, but one of the good thing is must thing is treat the underlying. So first non-pharmacological, then pharmacological, and reassessment. And with this, we finish the topic. Second lecture will be taken by Dr. Manish in will management and tools and updates will be discussed in detail. So I hope you like this session. Any feedback? I enjoyed this. Yes, Ashwin. If patient has both alcohol withdrawal and some organic, can we use benzodiazepine? This is okay. Thank you, Prashant. Because during my senior residency in one of the Dehradun college, I have multiple patient with this. I was very confused. Like patient has off क्या बोलते हैं, on abstinence of alcohol since last 3 days, and his LFT is deranged. But only so then you have to see whether it is deranged 3 to 4 times or it is 1 or 2 times. That is very common. GGT is highly raised, but AST not that raised. Then I proceed with the benzodiazepine, and I frequently go for a reassessment in different department, the condition of the patient. Sometimes you see the patient has respiratory failure, he's on a monitor, and patient is a known case of alcohol withdrawal. What will you do? Batao. How will you manage that patient? Anyone? Patient is on is on uh, respiratory support. No benzodiazepine, Dexmed. Very good. Or batao. Apart from Dexmed, what agent you can give? And another case can I also give? Patient has CNS injury, CNS trauma. He is in ICU. Known case of alcohol withdrawal, alcoहल यूज डिसऑर्डर. 2 दिन से एब्सटिनेंस है क्योंकि वो आईसीयू में है. अभी पेशेंट सडनली एजिटेटेड हो जाता है. बताओ क्या करोगे इस पेशेंट में विद द सीएनएस ट्रॉमा? यू कांट गिव कीटामिन इन अ सीएनएस इंजरी बिकॉज वो आईसीपी बढ़ा देगा, आपका बीपी भी बढ़ा देगा, ब्लीड कर देगा. तो नॉट कीटामिन इज नॉट इंडिकेटेड इन दिस पेशेंट. व्हाट विल यू डू? Dexmed is one of the thing that you can do in ICU setting, but in this patient, what you go? अच्छा बताओ बेंजोडाइज़ेपिन का मैकेनिज्म एक्शन क्या है? फिर हम कुछ ऐसा एजेंट देखेंगे ना जिसका सेम एक्शन है. मिडाजोलाम. ओके. ओके. एनीथिंग एल्स? गाबा. तो बेसिकली गाबा पे एक्ट करता है. पोस्ट सीएनएस इंजरी, व्हाट विल द वरी थिंग दैट वी शुड, दैट इज सीजर. सीजर का रिस्क बहुत रहता है. So usually for the acamprosate, सीजर से इंडिकेशन दे रही हूँ मैं. For the prevention of seizure, we start some agents that can also help in the alcohol withdrawal. बताओ क्या होगा? Yes, carbamazepine is one of the. You can go for a barbiturate, valproate, but you should know कि इन LFT कैसा है उस पेशेंट का. इफ पेशेंट अल्कोहल यूज का है, LFT बहुत deranged है, you can't go for the valproate or carbamazepine. Gabapentin is one of the thing that you can go. So recently gabapentin और pregabalin का रोल देख रहे हैं हम in patient having the CNS injury or CNS damage in alcohol withdrawal condition. Okay, so you have to think out of box when you see multiple consultation licensed patient na. So I will advise see as many patient you see in the different departments. मजा आता है बहुत. So it's not just कि benzodiazepine से ही alcohol withdrawal ठीक करना है. You have other agent. So for this you know the neurobiology of alcohol withdrawal. क्यों होता है withdrawal with delirium tremens? I am now able to enjoy delirium, ma'am. Okay, I'm also enjoying. It's just I feel like I'm a senior resident. I am teaching my juniors. So English glutamate, okay, and decreased GABA. Yes, that's why हम क्या देते हैं बेंजोडाइजेपिन. तो हमें गाबा इंक्रीज करना है तो हम और एजेंट से भी कर सकते हैं. ठीक है, तो इसलिए न्यूरोबायोलॉजी पता करनी चाहिए. ठीक है, एनी अदर डाउट बच्चों? एंड यू कैन ऑल्सो आस्क इन द ग्रुप. ठीक है, अभी 10 o'clock से ज़्यादा हो गया. हम सबका अटेंशन स्पेन 45 minutes होता है, इसलिए मैं उससे ज़्यादा. ट्रीटमेंट ऑफ डिलीरियम बेटा विल बी टेकन बाय डॉक्टर मनीष and recent advancement and tools that you should need to remember. I find that boring, so Dr. Manish will teach that. Especially if you have to remember one, I will suggest CAM ICU अच्छे से करना और बाकी सबके नाम याद कर लेना. ठीक है, Dr. Manish will teach in detail. I like this part, so I am covering it. The best lecture of delirium. Thank you. So we are planning intermittently. We are taking the session like a clinical cases approach because it's much easier to remember things now. So you don't, and neuropsychiatry, nothing to remember. Just know the basics and know how you approach the patient. Everything will be a cakewalk. Okay. Thank you. So अगर LFT ठीक है और benzodiazepine use कर लो in both ADS and organic cause. If altered, use some alternative. Yes, but अगर LFT ठीक भी है and you give benzos and you see there is a worsening, then you should stop that. And even in giving, start with very low dose and with monitoring and give some agent which is LFT safe. हाँ, अब बताओ रेस्पिरेटरी फेलियर एंड डेलीरियम, ये तो हम डिस्कस करना भूल गए. बताओ, उस बच्चे ने अच्छा याद दिलाया. Respiratory failure or respiratory compromise or patient on support. मैंने कब मना करा why not a camprosate? You can give. बट मैं बता रही हूँ कि एविडेंस बेस पे हम करते हैं ना. देयर आर मेनी अदर एजेंट दैट यू शुड सी कि इतना देते हैं एंड इन एवरी हॉस्पिटल देयर इज अ डिफरेंट प्रोटोकॉल. ओके, यूजुअली वी लर्न व्हाट आवर professors do, then we go and read why this agent is indicated. So acamprosate is not usually started in this. Okay, acamprosate usually हम acute phase में नहीं करते. If you see the role of acamprosate in alcohol use disorder is in maintenance phase, and its action is only on the maintenance phase is more common. Okay, Good, James. बताओ इसका तो बताओ, रेस्पिरेटरी कॉम्प्रोमाइज एंड डिलीरियम, हाउ यू मैनेज दैट? बेंजोस, और बेंजोस दोगे तो कैसे दोगे? और अदर एजेंट्स?
क्या हो गया?
So Dr. Manish is here.
Hello guys, I hope you
So
all have enjoyed today's session. Okay, benzodiazepines.
low dose atypical antipsychotic, one of the option, good Gary. And benzos with the O2 if saturation above, and dosing agent, whether you choose the short acting one and the long acting one. Lorazepam. Okay, very good. I like you guys started interacting. Any other option? We got two. Any other things? Respiratory compromise है, alcohol withdrawal है, DTA मतलब, how you manage?
Nice, sir. Ashwin, lorazepam. Great. If you're continuing with lorazepam, nice. What about other things? Melatonin.
Melatonin.
Very good, James. Melatonin. Any other agent you can think of? Starts with L. It's a Dora. Think about Dora. Dora. Lemborexant. Creation. Nice, sir. Lemborexant. Anything else apart from this?
In this, you avoid any benzos with T half longer. Okay? Dexmed हमने बोल दिया है.
What about propofol?
बताओ, इसका बताओ. Anyone? Just show your comments ना कि तुम क्या सोचते हो. Show your views. No, I think.
So basically, see one thing. You have to think like delirium is basically a disorder of circadian rhythm uh, abnormality. Okay, so circadian rhythm abnormality can be due to any of the aspect which Dr. Prachi has taught you. The etiology is anything which disturbs the basic functioning of neuron and it disturbs the circadian rhythm can lead to delirium. So you have to improve the circadian rhythm and also you have to correct the etiology that is leading to such kind of problem and also the neuron which is not functioning. That is why it is called as acute brain failure. Why it is called as acute brain failure? Because the brain cells have stopped functioning in toto. That is why you need to look into the cause. So, okay, so the management part we have to discuss. So we'll discuss all the case snippet based management. So don't worry about
So
this.
respiratory case, CNS trauma with the patient, and another with the multiple comorbidity.
You
That
can
will
use
be
carbamazepine also in the patient for management of this DT. Evidence is also for that. Okay.
like we discussed na GABA.
So this you
ठीक
can
है?
also use.
So okay.
Any role of magnesium? Have you seen magnesium oxide in management of uh, DT or withdrawal?
That also we will cover in the updates.
Have you heard about this magnesium oxide? Nowadays it is much more in discussion. Anyone? Low magnesium is the cause. No. Yes.
That we know. Hypomagnesium is one of the precipitating and even perpetuating factor. Very good, James. अच्छे से follow कर रहे हो तुम lecture.
James. So where are you, my dear James? Okay, fine. So I hope it was good for all of you that you have attended today's session. So next we are going to cover the neurobiology you have covered.
Yeah.
Okay.
So we will cover the tools the management and updates,
and I'll cover a brief neurobiology aspect also, the updated
and
ones.
the clinical vignettes,
Vignettes will cover in the next.
CNS, respiratory, CVS.
One thing I'll just like to clarify, if you give Nepal, great, antipsychotics are not the treatment for delirium. Please remember this. As of today, if you want to take anything, take home message. Okay, this message you should take that antipsychotic is not the treatment for delirium. Please
Okay.
keep this in your mind so that we can discuss
With
things.
this, we end this lecture. Any feedback and any comments, that any suggestion for the next lecture? Thank you, Ashwin. Very informative. Thank you, Abu.
Okay.
I hope you guys enjoyed it. Okay. So, always while having this, attending the live session, always remember, never think it is a one to one teaching. The main focus of our teaching platform is it should be a healthy discussion. Only then, मैम इफ पॉसिबल, हाँ मैम थोड़ा लेट बनाती है ना लेक्चर. नेक्स्ट टाइम आई विल ट्राई कि मैं वर्कबुक शेयर कर दूँ, क्योंकि यूजुअली मैं 9 PM तक एडिट ही करती रहती हूँ. सॉरी, दिस इज माई फॉल्ट. ओके अश्विन, आई विल ट्राई माई बेस्ट. थैंक यू ग्रहीता. तो चलो, गुड नाइट. कल revise this, otherwise you will forget. If you revise it tomorrow only, then you will able to retain. Okay, so next lecture it will be more easy for you.